this webinar, in which we discuss updates from the San Antonio Breast Conference, has been an annual event at NYU for many years. And the reason for that is that this is a very important conference to those of us who take care of breast cancer patients. It's an opportunity for us to learn about new developments in the field, to hear about the results of clinical trials, and to identify practice-changing information. So this has been a very important conference for all of us, and it's really our pleasure to be able to pass this information on to you in the form of this webinar. One last housekeeping point that I'd like to make. When you ask questions and you engage with the chat button at the bottom of the screen, please be aware that the speakers cannot answer specific questions about anyone's particular situation with breast cancer or their specific care. So ask the questions in a more general way, and then we will try as much as we can to stay on time with the presentations and answer the questions as we go.
Thank you so much. It's a pleasure to be here tonight and to talk to all of you about the radiation oncology updates from San Antonio 2024, which took place this past December. There were a number of really high impact trials that affect radiation oncology, so we'll go through them tonight. These are my disclosures. Okay, so we're going to start by talking about some trials that Dr. Schnabel is going to go into more detail in her presentation, but they have important implications for radiation, so I'll be touching on them as well, specifically how the omission of a sentinel lymph node biopsy affects radiation oncology. We'll then delve into the EUROPA trial, which is a trial looking at radiation or endocrine therapy in women 70 years of age or older. The preliminary 2-year results were presented at San Antonio and published, and we'll go through them together tonight. And then finally, we'll touch on post-mastectomy radiation therapy, which was dealt with in the Supremo trial, also presented at San Antonio this past year. And generally, and this is why it's so important that, Dr. Schnabel, Dr. Giabrio, and myself are all here together. Of course, all of our disciplines, while somewhat separate, are also very much overlapping. And this first part of my talk is really focused on when changes are made in surgery, how that affects the other disciplines. Okay, so the SOUND trial, which was previously published in JAMA Oncology in 2023, was a trial that was looking at the omission of sentinel lymph node biopsy in patients of all ages. So we'll talk about the patients who were actually enrolled on the trial shortly. And as you can see from the summary slide, it was over 1,400 women who were randomly assigned to undergo a sentinel lymph node biopsy versus no sentinel lymph node biopsy. It was performed in multiple countries. And as you can see from the curve on the right, there was no difference in outcomes. This is distant disease-free survival between those who underwent a sentinel lymph node biopsy versus those who did not. Now, importantly, all of these patients had an axillary ultrasound to show that they were clinically node negative prior to undergoing surgery. Now, even though the trial enrolled patients of all ages, you can see only about 1% were less than age 40, about 16 to 18% were 40 to 49. So for the most part, this was a trial in women over the age of 50. Most of these patients, over 90%, were estrogen receptor positive. And as you can see on the right in the red box, 98% or so of the patients received hormone therapy in estrogen receptor positive cases. So this is primarily women over 50 who are estrogen receptor positive who are receiving endocrine therapy in whom this trial is being conducted. In terms of the radiation details, and this is a key part of this, around 90% of patients received whole breast radiation. You can see that 83%, 81% received whole breast radiation up front. Another 3 to 5% received a boost followed by whole breast radiation, and only about 11% of patients received partial breast radiation on this trial. And these are all, of course, patients who underwent breast conserving surgery in whom we would typically give radiation therapy. Next slide, please. And presented in San Antonio this year is a very similar trial called the ENSEMA trial, which was over 5,000 women randomized in a 1-to-4 fashion, no sentinel lymph node biopsy, that was 1,000 women or so, versus sentinel lymph node biopsy, which was over 4,000 women. And very similarly, the primary objective was to compare invasive disease-free survival. There'll be a second randomization among the patients who are sentinel lymph node biopsy positive to a dissection versus not. And something that's very important to note, and this is true in the SOUND trial as well, that in the patients who had a positive in the patients in the sentinel lymph node biopsy arm, about 15%, and the number was similar in SOUND, actually had a positive sentinel lymph node. So it's not that none of these patients have positive nodes, it's that likely, despite even in women who might have had a positive sentinel lymph node, not performing the sentinel lymph node biopsy is not compromising outcomes. And similarly to the SOUND trial, you can see here the median age was 62. Only about 10.8% of patients were less than age 50, and 95.2% had hormone receptor positive HER2 negative disease. And the vast majority of patients over 90, around 95% got adjuvant endocrine therapy. As you can see, the primary endpoint, there was no difference between these two arms. And similarly showing very low rates of axillary recurrence or in-breast recurrence or distant relapse. In terms of the radiation on this trial, unlike the SOUND trial where it was left up to the individual investigators, all patients in this trial received whole breast radiation. The axilla was not targeted. Regional nodal irradiation was not permitted. Tumor bed boost was at the discretion of the treating radiation oncologist, and partial breast irradiation was not allowed. So this is really a trial of omission of sentinel lymph node biopsy with whole breast radiation. And the conclusions of the investigators, this is from San Antonio, was that, with over 5,000 patients enrolled, omitting the sentinel lymph node biopsy did not result in inferior outcomes. Patient had very good overall survival. And so based on who was enrolled in the trial, the authors say that this de-escalation concept is suitable for patients 50 or older, grade 1 to 2, because grade 3 was very underrepresented in the trial, hormone receptor positive, HER2 negative, preoperative tumor size up to 2 centimeters. And I added, this is in patients who are getting whole breast irradiation, which is really what the patients on this trial did. And these are some other ongoing trials of sentinel lymph node biopsy omission. Now, it's important to note, as I'm touching on this, right, that part of the reason we're focused on what the radiation was is that when we give whole breast irradiation, as you can see on the left, you do give some incidental coverage of the axilla. In red here is the level 1 axilla, and blue is sort of the outline of the radiation beam. So the low axilla does get some dose with whole breast irradiation, whereas with partial breast irradiation, if the tumor is in the middle of the breast, the axilla is not getting any radiation. If the tumor is in the upper outer breast, the axilla might get some radiation, but potentially it might be relevant that with whole breast radiation, we are treating the axilla, which, in the case of what we're discussing, we're talking about, a de-escalation of surgery to the axilla. And the other important implication of no sentinel lymph node biopsy are that many of the ongoing trials of radiation omission, like the DEBRA trial on the right, which we've opened at NYU, require a pathologically node-negative axilla. And therefore, if we're going to also omit sentinel lymph node biopsy in patients, that potentially will disqualify patients from these radiation-related trials. Now, just to remind everyone, we already in women 70 or older have some good data that it's safe to omit sentinel lymph node biopsy and omit radiation. This is a trial that was performed in the 1990s in women over 70, randomizing them to radiation versus not if they were clinically stage 1 and with hormone receptor positive breast cancer. And in this trial, about 64% of patients did not have any axillary sampling. And based on this, they're choosing wisely, and NCCN guidelines say that it's appropriate to omit sentinel lymph node biopsy in women over 70, and that it's also appropriate to omit breast irradiation in selected patients. So just to conclude this portion of the talk, how does the omission of sentinel lymph node biopsy affect radiation fields? Well, in women over 70, we already have data for both the omission of sentinel lymph node biopsy and whole breast irradiation, provided the patients are going to take 5 years of endocrine therapy, which was a requirement on CALGB. That was part of the study design. And so I would argue that by extension, partial breast irradiation should be okay in these patients, even without sentinel lymph node biopsy, because we already know that radiation omission is safe. In women 50 to 70, The data supports whole breast irradiation if the sentinel lymph node biopsy is omitted, as it was in Sounds and Encima. We have no data supporting the need to use radiation to cover the axilla to compensate for the lack of sentinel lymph node biopsy. That was not done on any of these trials. We have limited data for partial breast irradiation in these patients, and we need more data. And the lack of sentinel lymph node biopsy may limit clinical trial participation. And ultimately, all of the trial data for the omission of the sentinel lymph node biopsy with or without radiation is assuming patients are taking 5 years of endocrine therapy. Okay, so now we're going to focus, shift gears to the EUROPA trial. So these are some older trials that essentially had a no endocrine therapy arm. But other than these older trials, almost all of the newer trials, like the CALGB trial that I just showed you that were looking at radiation omission, were essentially randomizing patients to radiation plus endocrine therapy versus endocrine therapy, and did not have a no endocrine therapy arm until the EUROPA trial, which we're going to discuss now. So this was a phase 3 trial of 926 patients who underwent breast-conserving surgery with or without sentinel lymph node biopsy, who were pathologic T1 and 0. ERPR had to be greater than 10%, so estrogen receptor positive, Ki67 less than 20%, HER2 negative, age greater than or equal to 70 years. And they were randomly assigned to exclusive radiation versus exclusive endocrine therapy, right? Our standard of care in these patients until this point has either been to do both modalities or, as per the CALGB, just to do endocrine therapy. So this was really sort of first trial of its kind in the modern era. And the primary analysis was looking at IBTR, the its lateral breast recurrence rate at 5 years, which we don't have yet, and then the health-related quality of life at 2 years, which is what this analysis is presenting. And this interim analysis was planned when 152 enrolled patients reached the 2-year quality of life follow-up control, and that was this presentation, and they did not meet their stopping rules for recurrence or distant mets. Next slide. This is the patients in the radiation arm in blue and in the endocrine therapy arm in red. And they stratified by age 70 to 79 versus 80 plus, and by this G8 geriatric score class. And you can see among the radiation, 85% of these patients are getting partial breast and 15% whole breast, which is reflective of our general practice patterns in this very favorable patient population. Next slide, please. This is the primary endpoint. This is the global health score. Higher is better. So this is radiation in blue and endocrine therapy in red. And you can see consistently that the radiation therapy has higher scores, both at 3 months, but all the way out to 24 months. And then this is the change from baseline. Bigger change is worse. And you can see the radiation in blue has less of a change, which is more favorable. Next slide, please. There were no recurrences in either arm. Similar rates of contralateral breast cancer, no distant metastases, and no deaths related to breast cancer at 2 years. Next slide. Adverse events were more common in the endocrine therapy arm. If we look at grade 3 to 4 adverse events, you see none appear in radiation. There was 1 depression and 1 constipation. In endocrine therapy arm, you can see, about a 5.6% rate of grade 3 joint pains, 1.1% grade 4 joint pains, fatigue, hot flashes, muscle pains, bone pain, and depression. So the higher adverse events was in the endocrine therapy arm. Next slide, please. So the conclusions: radiation offers better health-related quality of life at 2 years compared to endocrine therapy. There's a lower incidence of treatment-related adverse events in the radiation arm. No warning signals for the stopping rules, but we definitely need 5-year data for the breast cancer outcomes. 2 years is not enough in this patient population. And the last patient was actually accrued this week to this trial. So hopefully 5 years we'll have results. But this is really exciting early data looking at just one modality versus another in this patient population and showing potentially that radiation has better quality of life and lower adverse events with no compromising of outcomes, with the caveat that we only have 2-year outcomes. And then finally, we're going to talk about post-mastectomy radiation with the Supremo trial. Next slide. This trial was entitled, Does Post-Mastectomy Radiation in Intermediate Risk Breast Cancer Improve Overall Survival? This is the 10-year results. Next slide. As background, we know that post-mastectomy radiation does improve overall survival from Danish and Canadian trials. This was, however, with older chemotherapy. And so this trial was looking at the role of post-mastectomy radiation in a more modern cohort. Next slide, please. With patients who either had limited nodal burden with N1 disease, or were T3N0, or were T2N0 with grade 3 and/or lymphovascular invasion who underwent mastectomy. They all had axillary lymph node dissection, which is, again, more of a departure now from our sentinel lymph node procedure, and they had adjuvant or neoadjuvant chemo. Next slide, please. And we're looking at the overall survival at 10 years. Next slide. It was powered for 1,600 patients and required 609 events. And patients were randomized to no chest wall radiation versus chest wall radiation. And you can see the numbers here of their over 1,600 patients who were randomized. Next slide, please. These are the baseline characteristics. And I do point out about 25% of patients were node negative, 75% were node positive, about 20% were HER2 positive, and about 10% were triple negative. Next slide, please. And this is the result for the entire trial population with no difference in post-mastectomy radiation in terms of chest wall irradiation versus not. Next slide, please. When they looked at node negative versus node positive patients for overall survival, there was no difference. Next slide. When they looked at local recurrence for all patients, you can see here that there was a difference in recurrence between chest wall radiation and not, with the chest wall radiation patients doing better. Next slide, please. And when they broke this out by node negative versus node positive, this was really driven by the node positive patients who had, a p-value of 0.01 and a hazard ratio of 0.3 for chest wall recurrence with chest wall irradiation. Next slide, please. And this was a regional recurrence, which you could see this trend for improvement with chest wall irradiation. And again, this is really being driven by these node positive patients who have the benefit for regional recurrence. Next slide, please. This is metastasis-free and overall and disease-free survival, no differences between the arms. So to conclude, in patients with 1 to 3 positive nodes, chest wall radiation did not improve the 10-year overall survival, though it did result in a clinically significant reduction. Actually, the authors are saying insignificant reduction in 10-year chest wall recurrence, no impact on disease-free or metastasis-free survival. And just some caveats I would add to that is that this trial did not actually irradiate the nodes in a lot of these patients. And again, a quarter of them were node negative and did not have sentinel lymph node biopsy. So somewhat limited in terms of how we can apply it to our patient population today, but still very helpful data in terms of what is the benefit of chest wall radiation. And then just to conclude the whole talk, we definitely need more data on partial breast radiation without sentinel lymph node biopsy. We need biosignatures to refine who does and does not benefit from radiation. More data on de-escalation of endocrine therapy like EUROPA, including introducing genomic assays into this space. And we know that not all N1A or limited nodal patients need post-mastectomy radiation, but does the trial apply with sentinel lymph node biopsy only? And we also need the publication to better assess results in subgroups. So with that, I'll conclude. Thank you all so much for your attention.
So I'm going to discuss the updates from the perspective of breast surgery. I am going to discuss some of the trials that Dr. Gerber discussed, but with a bit of a more critical eye toward the patient populations and the results. Here are my disclosures. So focusing on breast cancer risk and prevention, those of you who are familiar with this seminar from years past, I have discussed some of the modifiable risk factors that we understand can reduce patients' risks of developing breast cancer, and a lot of this has to do with obesity, exercise, etc. So it seems to be clear that inflammation in the fat tissue can increase the risk of breast cancer in women with benign breast disease. Now, while the rate of this inflammation in the fat tissue is higher in overweight and obese women, about a third of women with normal body mass index do still have inflammation in the fatty tissue in the breast. And these normal weight women who have this inflammation in the breast have higher aromatase levels, and aromatase is an enzyme that helps in the production of estrogen in the body. So this presentation from Dr. Iyengar showed us that you can actually measure certain markers that correlate with the damage that can be done to the breast cells from this adipose inflammation. And that this inflammation in the fatty tissue, which is generally correlated with BMI, can affect the immune microenvironment. Now, very importantly on this slide, we reference 3 separate studies that were done under different conditions, but all of them demonstrated that weight loss can improve the condition of the breast tissue and can improve some of these markers of DNA damage. And multiple studies at this point have shown that weight loss can be associated with a decreased incidence of obesity-related cancers. And this is, of course, very provocative right now with some of the emphasis on the GLP-1 drugs, etc. And it's possible at some point that this will become a new indication for those drugs to reduce the risk for breast cancer in at-risk individuals. So there was a very important presentation about risk-reducing surgery in women with BRCA gene mutations who also have had a breast cancer diagnosis. So this is the study. The background is that we understand that for unaffected women with these mutations, putting them at risk for breast and ovarian cancer, the benefit of risk-reducing surgeries is very well established. But we haven't had a lot of good information about the benefit of these surgeries in women who have already had a cancer diagnosis. So this study, which was international, multi-center, and hospital-based, was a retrospective study looking at women who were diagnosed between January of 2000 and December of 2020 with stage 1 to 3 invasive breast cancer, and specifically who were less than or equal to 40 years of age at diagnosis and had a pathogenic mutation in BRCA1 and or BRCA2. So this tells you about how the study was essentially conducted. And as you would anticipate, women fell into a variety of categories. Some of them had had risk-reducing mastectomies. Some of them had had the ovaries removed prophylactically. There was some overlap between the groups, as you'll see. But this is a mature study with a median follow-up of over 8 years. And here are the results. So first, looking at women who had risk-reducing mastectomies, meaning the removal of a breast prophylactically where no cancer was identified, showed a survival benefit in this study. You can see the separation between the blue curve and the orange curve that showed a survival benefit to women who did risk-reducing mastectomy, and this was new and important information for us. Now, if you look at this and you break it down in different terms, not just overall survival, but disease-free survival and breast cancer-free interval, you can see that the benefit is actually even a little bit more dramatic in showing the benefit of the surgery. And I think part of the reason why we see this dramatic difference is because this was a selected group of women who were quite young at the time of their original diagnosis, and the majority of whom hopefully survived their breast cancer and their treatment, and then went on to not develop additional breast cancer in the opposite breast over time. Now, this slide shows us the information about women who had their ovaries removed prophylactically. And this is actually not news. We've known for a long time that because of the lack of good, effective early detection methods for ovarian cancer, women who are at a high risk for ovarian cancer because of BRCA1 or 2 mutations do clearly benefit from having the ovaries removed prophylactically. So this just reinforced that finding. So the conclusions of the investigators showed that undergoing risk-reducing mastectomy and or risk-reducing salpingo-oophorectomy, removing the ovaries, was associated with increased overall disease-free survival and breast cancer-free interval in this very specific clinical setting of women diagnosed early with breast cancer. Now, these benefits were seen irrespective of whether the women had BRCA1 or BRCA2 mutations. However, the benefit of having the ovaries removed was larger in women who were BRCA1 carriers. And these effects of removing the unaffected breast and removing the ovaries were independent of each other, But the benefit of removing the ovaries was actually more pronounced in women who also had the risk-reducing mastectomies. So this was a very important piece of information, which I think supports the benefit of these interventions in young women who have these gene mutations. So now we're going to move on to some information that got a fair amount of attention at the meeting about the treatment of DCIS, which is non-invasive stage 0 breast cancer. So what I'm going to show you next are the results of what was called the COMET trial, which was labeled as primary outcomes following active monitoring or surgery plus or minus radiation for low-risk DCIS. And as you'll see in a minute, that title is a little bit of a misleading title. So this trial, which was a randomized multi-center trial, sought to enroll women with DCIS that was considered to be low risk. The criteria were supposed to be women greater than or equal to 40, new diagnosis of DCIS with no invasive cancer. It was supposed to have been low grade, hormone sensitive, and they included women with up to a 4-centimeter extent of disease. And then the women were randomized into 2 groups. One of the groups was called guideline concordant care, which meant basically following the typical guidelines, surgery at the time of diagnosis, and then plus or minus radiation treatment, plus or minus risk-reducing or chemopreventive endocrine therapy. But the other group, which was called the active monitoring group, is, to my mind, not exactly an active monitoring group, because these were women who had biopsy-proven low-grade DCIS, but they were permitted to have the hormonal therapies that we know can be effective at reducing the risk of future breast cancer events. So to my mind, that is not active monitoring, that is actually an intervention group. So this again goes over the eligibility criteria. They split the patients up into different groups based on their age and the extent of disease, etc. So here we're going to look at the flow. And here is where this data gets kind of messy, because women were assigned to the 2 groups, randomized 1-to-1 as per the trial protocol, but women crossed over between the 2 groups with some significant frequency. And as you can see with the lowest boxes that are circled here, there was a significant overlap between the groups that required the data analysis to also be done in a very specific and particular and kind of complicated way to account for the fact that women went in between the 2 groups, which generally in a clinical trial would not have been allowed. So now looking at what's called the intent to treat analysis, meaning if you split the women up into the group that they were randomized to, either the guideline concordant care or what was called the active monitoring group, you can see that they didn't see any change at the end of 2 years in the rate of development of invasive cancer. I'm being very specific about that as the endpoint, because this doesn't indicate women who had additional episodes of DCIS. It just focused on the rate of developing invasive cancer, and you could see that there was no significant difference between the 2 groups at the end of 2 years, which is not a very long time for patients with this sort of non-invasive breast cancer. Now, there were other endpoints that were looked at, including what sort of invasive disease was discovered in these patients who legitimately were being monitored very carefully. And you could see that there was no difference between the 2 groups in the invasive cancers that developed in that 2-year period of time. Now, here's where things, I think, really begin to question how the results of this trial are really going to be integrated into clinical practice. Because what you can see in the top box here is that 65% of women in the guideline concordant care group received endocrine therapy, but a larger proportion of them in what was termed the active monitoring group actually received this therapy. So again, that's not a non-intervention group. It's a group where the majority of patients did undergo some therapy, to reduce the risk of developing additional cancer. You can also see that less women in that monitoring group received radiation, but it's still 7%, which again, by the protocol would not have been recommended. And that there's a variety of different sorts of surgeries that occurred in both of these groups. Now, this analysis is what they call the as-treated analysis. So this was where the investigators attempted to account for the fact that women did go between groups. They did overlap. They did go from one group to the other. And it's complicated here because now, instead of having 2 groups, we've got 4 groups. And I do not believe that this was a planned analysis in this trial, because when you do a trial, you assume that the groups will remain as they are through the duration. But with this complicated analysis, again, they didn't see any change in outcomes. So the investigators' summary goes like this. In this pre-specified primary analysis, again, at only 2 years, the rate of invasive cancer was not different between the 2 groups. And when those cancers developed, there didn't seem to be any lack of benefit in terms of early detection. However, almost a third of the participants in this study did not adhere to their group allocation. And while there was no obvious imbalance that the investigators could discern, this cannot really exclude the idea of participation bias. Now, this early analysis has been published. You can see below in JAMA. It was published online. But because of these questions about the way the trial was conducted and the overlap, et cetera, in my opinion, this is not very convincing in terms of allowing us to ascertain the idea that we can recommend to people specifically an active monitoring intervention when they are diagnosed with DCIS. So further, as a companion to the trial, they looked at patient-reported outcomes for the 2 groups. I think that the question was, will we be helping women by offering them only medication therapy versus surgical therapy for their DCIS? Will that lead to a better quality of life? And again, remembering that the majority of women in the active monitoring group did take endocrine therapy. And for those of you in the audience who have ever taken endocrine therapy for breast cancer, you know that that is not easy. And it's something that can be very difficult to adhere to for the full 5 years. So just a quick summary here, they did not see any difference in patient-reported outcomes between these 2 groups. So the absence of surgery did not result in better quality of life measures for the group that was labeled active monitoring. So now we're going to talk a little bit more about this omission of axillary surgery. And again, I know that Dr. Gerber covered this. We're going to cover it from a slightly different angle. As we think about the treatment of breast cancer in all regards, we do try to focus on giving people effective therapy, but trying to right-size that therapy so we don't overtreat people and avoid preventable side effects and consequences. So this concept of de-escalation has been extremely important over the last number of years. And the ENSEMA trial was something that looked at no axillary surgery versus sentinel node surgery in women with early stage breast cancer and breast conserving surgery. Now, this trial was an international trial, and it was basically done in Germany and Austria. And women had to be above 18. They had to have cancers in the breast where the primary was less than or equal to 5 centimeters. They had to be clinically without lymph node involvement. A little bit different from the SOUND trial. Planned breast conserving surgery and planned for postoperative irradiation. And Dr. Gerber has covered that aspect of it. The randomization was 1:4. And the key primary objective was to compare disease-free survival, invasive disease-free survival between the no axillary surgery and the sentinel node patients. So these are the baseline characteristics. And you can see that in general, the groups seem to be well matched. But just again to point out to you that only about 11% of patients were under 50. So this doesn't apply to all age groups. And the vast majority, 95%, had hormone-sensitive HER2 negative breast cancers, which we know to be, in general, the best prognosis subgroup. Now, you can also see, by the way, from that slide, that they did include a few patients in the triple negative and HER2 positive groups, which again, you would assume would not have happened based on the trial criteria. So now looking at results, when we look at the results in terms of comparing the no sentinel node group versus the sentinel node group in terms of axillary recurrence and recurrence within the same breast, you can see that there does not appear to be a significant difference between the two groups. There was no difference in developing disease in the opposite breast, and certainly no difference in terms of distant relapse or death between the groups. So the conclusion of the investigators is that with this trial that enrolled over 5,000 patients, it identified the fact that omitting the sentinel node procedure in patients who were clinically node negative with early breast cancer and scheduled for breast conserving surgery did not result in an inferior outcome. And in general, patients in both groups did very, very well. The investigators did comment, of course, that this does not apply to every patient with breast cancer. This was really a trial that, in the main, looked at women over 50 with low risk characteristics of their breast cancer. But it's part of this method, these metrics, to try to help us identify a subgroup of women for whom even removing the sentinel nodes, which we know has very little morbidity, is not necessarily required in the presence of post-lumpectomy radiation therapy, which Dr. Gerber covered, and appropriate medical therapy. Please. So those are the caveats. Now, we talked about the SOUND trial a little bit. The SOUND trial was another trial that was designed quite a while ago to look at, again, patients with small breast cancer and clinically negative lymph nodes, but this trial required an ultrasound showing no abnormal lymph nodes in the underarm area at the time of diagnosis. So again, looking at the trial with a bit of a more critical eye, they did, this was a trial done in Italy, Switzerland, Spain, and Chile, a total of 1,463 women of any age. So they did not seek to look for older women where we know the prognosis may be better. Breast cancers, again, up to 2 centimeters, and a negative preoperative axillary ultrasound. And they were randomized between 2012 and 2017. And randomized 1-to-1 to receive sentinel node biopsy or no axillary surgery. So the criteria for entering this trial were a little bit more vague and a little bit more inclusive, and I'll even draw your attention to the idea that a few patients in each group had DCIS or LCIS within and not invasive cancer. So again, this was on the one hand, enrolling lots of patients is good. On the other hand, the criteria were a little bit looser, and perhaps that's an issue in terms of our results. So now again, looking at the results between the group that had the sentinel node biopsy and the group that did not, it appeared that there was really no difference in terms of the key indicators of recurrence within the breast, recurrence in the axilla, distant metastasis, etc., and no change in breast cancer-related deaths between these two groups. And these are just some Kaplan-Meier curves that essentially show you the same thing. There does appear to be some minimal separation of the curves as we get a bit farther out. It'll be interesting to see these patients followed a little bit longer. Given that they are patients with very early cancer with generally a good prognosis, longer follow-up is, of course, always more illuminating. So they found that omission of axillary surgery was non-inferiority with small breast cancers and negative axillary ultrasounds, again, trying to find more data to help us finally identify a true cohort of patients where we can omit this surgery. So in summary, we know that hyperadiposity is a modifiable risk factor for breast cancer, and methods to decrease weight and increase physical activity can improve the biomarkers and reduce breast cancer risk. Young affected BRCA mutation carriers have an improvement in survival with risk-reducing mastectomy and or risk-reducing removal of the ovaries. And this was seen in both BRCA1 and BRCA2 carriers. The COMET trial, and I've kind of been very clear about what I think the limitations of the trial, very early data did not show a difference in the rate of invasive breast cancers in these patients, but there was a significant overlap in treatment between the two groups, and the active monitoring group was not exactly an active monitoring group. Both the SOUND and ENSEMA trials demonstrate that for particular cohorts of older patients with low-risk disease, omission of sentinel node biopsy does not appear to affect overall outcome, but a big caveat is this strategy cannot be applied to patients with triple-negative and HER2-positive subtypes. As Dr. Gerber mentioned, the downstream effects of losing this data have to be considered as decisions are made regarding systemic therapy and radiation therapy. I think that it's quite possible that certain genomic assays may be helpful in better clarifying these groups, and there are also implications for clinical trial eligibility and participation. Thank you.
Let me start by saying, medical oncology bookends this talk today, but we're the three pillars, as you know, and there's a lot of overlap between the three of us. So I have no disclosures. The abstracts I've picked today are, there's so much wealth of data at San Antonio, but I thought they had takeaways for daily practice for the majority of our patients, something that we could use on the Monday morning that you come back from San Antonio. So I'm going to cover very quickly hormone positive, HER2 negative in the early stage and then the advanced setting, two specific abstracts, the TAILOR-X update and the EMBER-4 update, and also talk about one more that in the body of this, as well as something for HER2 positive and triple positive, hormone positive, HER2 positive cancers, the PATINA trial. So very quickly, for early stage breast cancer, as you know, genomic assays have revolutionized the way we treat patients. The TAILOR-X study, which you can see on the left, was the inclusion criteria, the study scheme. Randomized women with intermediate risk scores, oncotype or the recurrence scores, to receiving chemoendocrine therapy versus endocrine therapy. And those in that intermediate category between 11 to 25 did not seem to benefit from chemotherapy if they were postmenopausal, with some differences in the premenopausal depending on clinical risk. Now, what was important about this abstract that I'm showing you today is the retrospective analysis of Arm D, or the patients who got chemo on Arm C. So it was really the patients who ended up getting chemotherapy. And for the longest time, we oncologists struggled with how much is too much, which chemotherapy should we be giving these patients. These are all node-negative patients. The two regimens that you may be familiar with are TC, Taxotere and Cytoxan, or a combination of Taxol and Adriamycin and Cytoxan. Adriamycin, which is an anthracycline, is associated with a low risk of leukemia and heart failure. And so in general, we've tried to stay away from using Adriamycin if we can help it. As you can see, out of all of these patients, the vast majority did receive TC. But after they controlled for age, grade, tumor size, estrogen receptor, progesterone receptor status, they found that the benefit of giving this three-agent chemotherapy, the anthracyclines, was really seen in patients with recurrence score 31 or greater, and those who had tumors that were 2 centimeters or greater. The vast majority of women did not seem to benefit, even if their recurrence scores were above 26, but less than 30. So what I took away from this is that anthracyclines really could be reserved for the highest risk hormone positive patients. Now, this is retrospective data. It's not level 1 evidence. And so there are a lot of nuances that might come into play. For example, looking at the Ki-67, for example, the grade of the tumor. So we make these decisions on a daily basis, but it is comforting to know that for the vast majority of our patients, who even with a high oncotype score, we might be able to get away with less chemotherapy. The next abstract that I'm going to talk about, just a little background, as you know, for advanced hormone-positive, HER2-negative cancer, the CDK inhibitors, familiarly known as Ibrance, Kisqali, Verzenio, palbociclib, ribociclib, and abemaciclib, have really changed the standard of care and are now also being used in early-stage breast cancer. The progression-free survival with the addition of these drugs to an aromatase inhibitor, which is the standard of care for frontline therapy for metastatic hormone-positive, HER2-negative cancer, is really pretty similar between all three drugs, about 14 months. It increased by 14 months compared to, so 24 months versus 10 months with just the aromatase inhibitors alone. But the holy grail for oncology always seems to be overall survival. How long does somebody live after a particular treatment? And numerically, it seemed to be longer with all three. But statistics do matter, and statistically, ribociclib or Kisqali seem to have the edge, and numerically, abemaciclib gave us a clinically meaningful benefit. And so we're always struggling with which one to pick. What about side effects? There was a question in the chat about quality of life. That does matter, and that may not always be quantifiable with just talking about adverse side effects in the clinic. What about the economic side effects? All of those. And the sad part is we didn't really have studies that compared them apples to apples against each other. They were all three different trials in different populations. So if you look at side effects, and here's where quality of life does matter, there are some differences scientifically, but just coming to the common adverse effects, the AEs, low blood counts, diarrhea, and nausea are very common with abemaciclib, but low counts are much more common with Ibrance and Kisqali, whereas we don't see as much GI toxicity, the diarrhea. Whereas we know that Kisqali can sometimes elevate what we call QTc, the EKG, and might require more monitoring. So all of these matter for patients who have to travel long distances, how frequently they need to be seen. And so when putting that into perspective, what do we do in the clinic when we have patients where we have 3 drugs, so we have a wealth of data? This was a study I thought that was really relevant to daily practice. It's called the P-Verify. It was a poster presented by Hope Rugo and colleagues, which was a comparative overall survival of CDK inhibitors. So this was not a randomized study, but in the real world US setting. What they did is they took data from Flatiron, which is a very large database, as you know. It was a retrospective study. And they looked at patients who are getting all these 3 drugs in clinics across the country. And as you can see, a vast majority did get Ibrance. This study was started back in 2015. In 2017, when the use of ribo and abema became much more popular, there was an amendment to sort of adjust for that. And the bottom line was, if you can look on the right, you'll see that whether they used an adjusted, standardized inverse probability of treatment weighting or an adjusted assessment, there was actually not much difference in the overall survival between all of these, which gives us oncologists some comfort when prescribing these drugs for somebody, for example, who has cardiac toxicity. So we may not be always giving up who's living longer versus who's doing better on these drugs. And that was, I thought, very relevant for us. We still try to use data. Ribociclib tends to be our frontline therapy for premenopausal, for example, women, but very comfortable switching between these drugs if patients cannot handle one compared to the other. So that was my takeaway, which I just revealed. Safety and quality of life are equally important. Now, the other big news and the other big direction that we're moving in is finding a different endocrine therapy. We've talked about some of the side effects of these medications that can be terrible. We know that resistance mutations develop in the estrogen receptor called ESR1 mutations, and that leads to resistance to drugs like aromatase inhibitors, where the receptor is on all the time. And so whether you bind estrogen or not, this keeps working. There are many drugs in the market to target estrogen. Receptor positive cancers, aromatase inhibitors just block estrogen production. SERMs like tamoxifen bind to the receptor, but the new class of drugs called SERDs, which is on the extreme right of that cartoon, also degrade the receptor. And what is intriguing is that they actually can work even in the presence of the ESR1 mutation. So in a familiar one, maybe Orserdu, elacestrant, which has already been approved in the metastatic setting after patients progress on frontline therapy with an AI and CDK. And so like we do in oncology with everything, if drugs are working individually, why don't we put them together? So this study, EMBER-3, looked at a SERD in combination with CDKI compared to just the SERD alone, or using an aromatase inhibitor or fulvestrant, which is the standard of care therapy. And this included men and women who had progressed on that frontline therapy with an aromatase inhibitor or fulvestrant and a CDK4/6 inhibitor. And the bottom line, again, was that if you combined this novel endocrine drug and the abemaciclib, it seemed to be really beneficial regardless of whether you had an ESR1 mutation or not. We know elacestrant is only approved right now for women with ESR1 mutations, but if you look on the right, single agent SERD didn't seem to be all that different. But when you combined a CDK, it seemed to be even better in patients who had CSR. So this may be the way for the future, where we are looking to add drugs that might have a safety profile. Safety, as you can see, was well described here. Unlike just the aromatase inhibitors, SERDs actually cause less of the joint pain, hot flash side effect. It's not zero, but much less. So most of the side effects were really from the abemaciclib or the Verzenio. And my takeaway is that probably a combination is going to be the way of the future. There are trials ongoing already in looking at these combinations, such as the Elevate trial at NYU. And lastly, for triple negative trials, triple positive trials, those that are hormone positive and HER2 circled here in the middle, where you have two sort of pathways that drive the cancer, we've always treated all HER2 cancers the same. Everybody gets chemotherapy based on something called the Cleopatra trial, which was approved back in 2013, using 2 chemos and 2 HER2 blocking antibodies compared to 1 blocking antibody. And 37 of patients are still alive with that treatment at 8 years. So this was our frontline therapy. Potential new standard alert, we might be seeing TDXD coming up in the future, replacing the chemotherapy portion of this. Time will tell in the next few conferences coming up. But what the study looked at, the Patina study, looked at adding a CDKI. Again, as I said, the word on the street seems to be combination seems to be better. So after patients finish chemotherapy, or they have 6 cycles of treatment, we maintain them on just the aromatase inhibitor and the HER2 therapy. This study added the CDK to this. And as you can see, there was a 15.2-month longer progression-free survival, but just adding that CDK, it went to 44 months. That is a pretty dramatic improvement in the outcome of these patients with fairly standard side effects, which we know how to handle, the low blood counts and fatigue, never without side effects, but things that we're familiar with Ibrance. And so my takeaway is that adding the CDK after you finish this induction with chemo may be a great way to maintain these patients and maybe even pave the way for a no chemotherapy approach in the future. When you have such great numbers, maybe these patients may not need chemotherapy in the future. So looking forward, SERDs are moving into the early stage setting. Combinations seem to be the path forward, and we might be looking at a chemotherapy-free option for triple positive cancers. With that, I would thank you for your attention.
Yeah, great question. So, what I would say is because some of the limitations I was mentioning in terms of all patients having had axillary lymph node dissection, I'm not sure it's going to change guidelines across the board, but certainly I think it adds to our knowledge that there are patients with more limited disease who do not need post-mastectomy radiation. And we also right now have the ongoing MA39 or a Taylor RT trial. This is open at NYU, and it's similarly saying in patients with 1 to 3 positive lymph nodes patients with 1 to 3 positive lymph nodes with an oncotype less than 25, we're randomly assigning them to radiation versus no radiation. And I think this will really help us clarify, whether there's a lowest risk group of patients, even node positive, who don't need post-mastectomy radiation. So we definitely need more data in this space to really figure out who we can safely omit post-mastectomy radiation in. The reason I would say is that's really, in some sense, the most favorable group of patients with the lowest risk of recurrence. If this trial shows that endocrine therapy or radiation therapy alone is safe, potentially we can try to extend this to a younger age, but we're really starting with the lowest risk patient population, as this is a de-escalation trial, and we always want to de-escalate very slowly and very carefully. So in terms of proton therapy and breast cancer, as of right now, proton therapy is not used as standard of care in breast cancer. There is the ongoing RAD-COMP trial, which is looking at protons versus photons. Photons are normal radiation in node-positive women. And we'll await these results. But, this trial will show is there any cardiac benefit with protons in node-positive patients. But as of right now, in terms of standard of care, there is no official benefit of protons over photons, and we need more data to see if it's at all beneficial. And protons, while they potentially offer some sparing of the heart based on the dosimetry, we also know they can sometimes increase the skin dose and also the risk of reconstruction complications. So as with everything, we don't want to introduce new technology until we show that the benefits outweigh the harms. So it's important to test this as we're doing in the RAD-COMP trial.
So I think the big success story, which is still to be borne out in phase 3 trials, but is the role of immunotherapy in our estrogen positive breast cancers. We've certainly seen that Keynote 522 has revolutionized how we treat triple negative cancers, but we do have patients that are estrogen positive but high risk, what we call the basal type estrogen positive, where we know from data from I-SPY that these patients actually benefit from the addition of immunotherapy. So there's a very large trial ongoing called the SWOG 2206, which is actually randomizing these patients with these high-risk estrogen-positive cancers to immunotherapy in combination with chemotherapy. And based on the prior data, the preclinical data, it seems like this might be a success story for the really high-risk patients.
And of course, the risk is that patients will progress to not just a recurrence of DCIS, which certainly could happen and require additional intervention, but could be diagnosed with invasive breast cancer, in which case the treatment paradigm and certainly the long-term outcomes will be entirely different. And that's something that we would like to avoid whenever possible. The diagnosis of DCIS in many ways is how mammography saves lives.